background is pure internal medicine. But to make it clear that every pharmacist should be a drug information specialist. So it is not my specialty, but I think that it is everyone's specialty, the drug information resources. So we'll talk about drug information resources from A to Z in a simplified way. So I hope that will be an enjoyable presentation to everyone. My target audience, as they told me, the invitation is a student and just a recently graduate student. So I try to make it as simple as I can, so can everyone understand all the language of the presentation. So the outlines, we'll talk about 4 points. I think is very important for a new graduate or even the pre-graduate students, so they can understand all these things. So the first point is applying a systematic approach to drug information questions. So I believe that every day we face questions, even from our family. So drug information questions not necessarily in the hospital. It is any questions related to the medication or to the drugs. So we need to know how we approach these questions. Is it just direct answer, or we need to go in deep? So we'll talk about this point in detail in the first point. Then we'll go to identify drug information resources. So what's the different resources of drug information? How we're gonna approach any questions that comes and put it in an evidence-based matter. Then we'll go to the clinical trials, and this is a special request from my students that they want to know how to do a critical appraisal of a randomized controlled trial. So I include that in my presentation. So how to evaluate a randomized controlled trial and how to do a critical appraisal. Then we'll talk about just a few slides about evaluation of internet resources. So the easy way is to go and Google any question, but is every website is valid? Is every website is trustable? That's a question mark for the last point. So my presentation will be an interactable presentation. So we have questions you need to answer, then we'll see your answer, then we go and proceed with the slides. So to talk about drug information history, starting from 1960s, the concept of drug information or the term of drug information was in 1960s. Then in 1962, this is the first drug information center was in the University of Kentucky Medical Center. So they try to develop the concept of drug information in 1962, and was the first drug information center at that time. Then in 1964, the first conference for drug information. Then in 1967 is the drug information specialist term that comes, and now from that time we have a drug information specialist. Nowadays we have very specialized drug information people. My colleagues in the career, that we have many consultants in drug information. Yes, drug information is very important in any healthcare sectors. So saying that we have many questions that comes on daily basis during rounds, inpatient, outpatient, even in community pharmacy, even as a medical rep, there is many questions that come to us from our family. They ask us about many medications, so about drug information questions, about many medication, how to use it, how to dilute it, how to compound it, can be diluted with water, can be diluted with normal saline or dextrose water, what different kind of questions. I'm sure that on daily basis, once you enter a pharmacy school, and the first day you will get a drug information questions. From the first day, from your family, they will say that, oh, you are a pharmacist. In the first year, you should know everything. So how to answer them, how to get the information from them. So you need to know all these things. So the first questions in our pool, I think I can share the question with you. Sorry. The first question is the physician asking you or a pharmacist or drug information pharmacist about the dose of meropenem. So a simple questions, dose of meropenem. So what's the first step of answering this question? Either asking the requester name and specialty, categorize the question, answer the question without further details, or ask about patient information. So we need to know. So the first question, I need to launch it. I think now is for voting. You have just 5 seconds. Let's make it 10 seconds. So I see many response now. So waiting for others. Oh, still the variety of answers coming. Any more answer? No. Oh, still. Okay, so let's share the results with you. So this is the results. So I can see 73% of you will ask first about patient information. And nobody say that, answer the questions without further delay. And that's good. That's amazing for me. And just 7%, they say that they categorize the question. And 20%, they say that ask the requester name and specialty at the beginning. So let's see the answer. So the answer actually is the first answer. So we ask the requester name and specialty. And this is the first step. We secure the demographic of the requester. So we need the requester information. So is the requester is a physician, pharmacist, nurse, is it a patient? So we need to know who is the requester, what's the information, so what's his number so I can call him again. So we need all this information from the requester first before asking about the patient's information. The second step, yes, to obtain background information. So we know that's now we secure the demographics of the requester, so the physician, the specialty, so I know where is the direction of the question, so I can ask more questions. So then we obtain the background information. So resource the requester has already examined. So did he search any resources? For example, did he search lexicon? Did he search any websites? Did he Google it or not? So we need to know all these things. Patient-specific information, so age, weight, height, diagnosis, any other relevant medical problems, allergies, renal function, liver functions, other drugs that the patient's on, either OTC or other things. So we need to know all these things. Then we'll move to the things that when the last time he took the medication, any medication that's with this medication will be prescribed, and the urgency. It's very important to know the urgency of the question. Is it very important to answer it now, or that you have time? You have 1 hour, 2 hours. The patient still it's not the time for the dose. So we need to know is the patient is coded in the ICUs and need the answers immediately or not. So we need to build a time frame of answering the questions. So saying this, so we need to have the background information, and that's to clarify the question, and it's a very critical step. And the question may not state it concisely. So sometimes we have a fake questions. The dose is not the right question. So the requester doesn't know how to ask the question, for example. Or sometimes the questions he asks is misleading to another things. And you keep searching to answer another question that the physician or the requester did not ask that question. And this is not the answer for him. So you need to know specifically what's the kind of question that he's asking. You need to clarify the things from him or from her to know where to search. then to formulate an acceptance response. So you know that specialty, you know the demographics, you know the whole information. So now you can tailor your question to the right answer for your requester. So the step 3, that to determine and categorize the actual question. So we need now we know the question. Is the question as ADR, at first drug reaction? Is it a dose? Just we go with the dose references. Is it an administration issue? Is it identification? For example, I don't know the bill, what is the bill as for. So I have an anonymous bill. I don't know what is it. Is it beta blocker? Is it paracetamol? I don't know. I need to identify it. Yes, there is resources for that. Interactions, drug-drug interaction, herbal-drug interactions, all these things I need to know. For example, if the physician asks you, what is the drug interaction between my medication and other things? So this is a big question. So is it herbal? For example, warfarin. Is the question is interacting with herbal? Is the question is interaction with another medication? So we need to know. Pharmacokinetic questions. We need to classify. Teratogenicity questions. Is it toxicology questions or is it a simple questions? So we need to know what's the category of questions to make the search strategy is easier. So now once we know the category, we can develop our search process. So now we move. Do we need to go with the primary resources? Do we need to go with the secondary resources or the tertiary resources? So all these things is very important. So all these things is very important to know that after categorization of the question, you need to know where to search. So then we perform an evaluation, an analysis, and synthesis. So we got the information from the resources. So now we need to build an answer. We don't say that this is the article and search it by yourself. We don't give the physician or the requester the full article, for example, or the full website to search about it. So it is not the way. If they call you because they don't know the answer, they call you because they don't have the time to search about the answer. So you are the drug expert, so you need to search the answer for them. So just build your answer, concise, make sure that you answer everything in the questions with the reference. Then after that, you formulate and provide the response. So once you formulate the response, how to formulate it? So to present the competing viewpoints. What's the meaning of that? Competing viewpoint. So let's say that I have different dose and Lexi and micromedics. I must say that this is the reference and this is the dose. For example, for the antibiotic, we have LexiComp, we have Sanford Guide, we have micromedics, for example. This is an online search. You can search about the dose of a medication, for example. So once you search, sometimes you have different answers. So you need to provide with the different answer, and the physician will decide which answer he needs. Or you should provide which is the best evidence regarding that question. Then you say that this is the best evidence, and otherwise we have all this evidence and they are saying this and this. So you can just go and manipulate your answer and show them that you search and your strategy of searching is the answer from the primary resources, is it from a secondary resources, or is it from a tertiary resources? So you need to let them know, and you need to show them where is the reference, from where you got the information. And after that, you need to show them how comprehensive you search, and you give them the answer. So, and why is that? Because without show them that you search and you did your part, they will not trust your answer. So now step number 7 of answering a DI questions is to conduct a follow-up and documentation. So after answering, you need to have a proof for your answer. So you answer questions, and after like 30 days, the patients die, and they did an investigation. So From where you got the answer, I will ask the physician, from where you got the answer, they will say that from pharmacy. Pharmacy, do you have a proof that your answer is this? You will say, no, I have no documentation. So you will have a legal issue regarding this. So you need to document in the patient profile that this is the question, and this is your answer, and this is your reference. So to protect yourself and to show that the pharmacy have a value in the institution, so you show them that you are a valuable person in the institution, so they can rely on you. They cannot work any institution or any hospital without a pharmacist. So showing this, yes, they will say, yes, we need pharmacy all the time. So I hope that the first part was clear to you. Now we'll move to a very interesting part, the drug information resources. So what's the drug information resources? So is it, as I mentioned, primary or secondary or tertiary resources? So first of all, we need to test our knowledge. So again, it is very interactable session. So we will have another questions. So the question is the secondary resources for drug information or for information compromised of. So secondary resources now. Is it a textbook and research monograph? Is it a subject periodical and encyclopedia? Is it indexing and abstracting periodicals? Or is it a bibliography and patent? So now we'll have another pool. And now it's launching. So I hope everyone is participating. So we have just 43% response. So we need to know more. Anyone like to answer? Okay, so let's see the answers. So the majority of you saying 45% few saying that indexing and abstracting periodicals is the right answer, and 36, and quite good number, saying that 36% of you saying textbook and research monographs, and 5% saying subject periodical and encyclopedia, and there is 14% saying bibliography and patents. So what do you think the right answer? The right answer is with the majority. So the majority saying is indexing and abstracting periodical. Yes, this is a secondary resources, and we'll go with that. We'll go in that in the few slides in detail about these things. So the other question is article published in a research journal. Is it a reference resource? Is it a secondary, primary, tertiary resources? So we'll go with the next pool question. So we'll see your answer now. So we have 75% responder. So let's see, what's your answer now? So this is the answer. We have 12% saying it's a reference resource. We have 80% saying secondary source. And we have 62%, which is the majority, is the primary source. And we have a 19% saying a tertiary source. And actually, you got the answer. It is a primary source. So an article published in a journal, it is a primary source. So now we'll move to this slide. I promise you that we'll go in details in these things. So what's the primary? What's the secondary? What's the tertiary source? And it's very important to know all these things. For a new graduate, for any pharmacist, we need to know what's the resources we have. So starting with the tertiary resources usually textbook, which is not indexed, textbook not indexed, Compendia, review article. These are the tertiary resources. So these are usually general information they have. It's not indexed information. So usually we use them as to have a very quick answer. And it's this very initial place to search in your question. For example, you have a question for anything. Those, you go with the box, or you go with the search. Then we'll go with the searching. Now we have the applications, we have the new technology. We'll go with the classification with that. But now the tertiary resources is a review article, textbook, Compendia, which is just general information that give you from these references. And usually it is an initial place to identify the information, and usually give you a complete, concise answer in a very short period. So we'll have in the next few slides, we have different examples of the source, the textbook, for example. If you have a question for general products, you can go with the drug information handbooks, AHFS drug information. So all these things is just to have a general product information, just those first drug reaction, or just general information about the medication. Now we'll talk about adverse drug events or adverse effect. We'll talk about Miller's side effect, which is a very common reference for adverse effect. And we have the common medication reference, the general medication references, which is a drug information handbook, or we can go with the Micromedics or Thomson Reuters reference. So now, again, questions. So we'll have many questions today. So let's see. The question is: primary teams prescribe an itraconazole suspension, and you are in the pharmacy, and the questions come to you that you don't have a stock of suspension. You have only the capsule of itraconazole. So which reference you will use to make the suspension from the capsule? So is it Myers? Is it Remington? Is it Stockley? Is it Briggs? So I hope that you got it right. So we'll have the question now. You can answer now. Can see very fast response from you now. You become an expert now of answering questions. So compounding a medication from capsules to have a suspension. From where we got this information, and it's very common. It's a day-to-day questions that comes to pharmacy. We have 60% response. Need more. No more answers, so we'll have the answer now. So from where you can get the answer? Itraconazole, we have the capsule, and you need to make it a suspension. So Remington is the right answer, which is one of the famous book for compounding. And we have other books like Handbook for Extemporaneous Preparation, Pharmaceutical Compounding and Dispensing, and we have many others references, but this is a very common references that used in pharmacy. Coming to the third answer that you mentioned, that majority of you saying Stockley is for drug-drug interaction, herbal drug interaction. And this is the answer for drug interaction questions. And we have drug interaction analysis and management. And this is one of the resources that's used for drug-drug interaction or herbal drug interactions. Laboratory results, laboratory tests. We have different book for interpreting laboratory data. We have laboratory test and diagnostic procedure book. We have laboratory test handbook. We have different books for a laboratory result to be interpreted. And it's very important for us to know how to interpret a lab result. And who said that the Briggs, the last answer, it is Briggs from the name, it is pregnancy and lactation. So we have different sources for pregnancy and lactation as a tertiary resources. We have Lactamed, we have prescribing pregnancy, we have drugs during pregnancy and lactation, and we have drug in pregnancy and lactation, which is Briggs, which is the author is Briggs, and they call it Briggs, and it's very famous book for drug pregnancy and lactation. For pediatric, and I'm sure that most of you know pediatric dosage handbook or new facts, and we have the very famous book, which is Heart Lane Handbook for Pediatric, who got a question for a pediatric dose or adverse drug reaction for a medication, anything regarding pediatric dosing, you will find it in a Heart Lane or a new facts or pediatric dosage handbook. Now, the last part is toxicology information. So you have a poisoning question. You have different questions for poisoning or toxicology, and this is the right sources, resources to search in. Either Lexitox, which is considered as a tertiary, Thompson or Micromedics, if it is indexed answer, it is a secondary, but if it is not indexed, which is a tertiary resources. And we have the book, which is Poisoning and Toxicology Handbook. The secondary resources, usually in a simple way, I explain to my intern or my students that secondary resources, it is a gate for a primary resources. So PubMed, all of you know PubMed. You will put your search, you will have the primary article, you will have the original article, Cochrane Library, Google Scholar. So you search, you will have, this is the gate or the gate for the primary resources. And Micromedics considers a primary, consider as a tertiary or for a tertiary or secondary resources. I don't include it here. I don't want to confuse you. So Micromedics, because it has an index and reference inside the website. So once you search a medication, for example, you have the index, you have the reference after each point and the result of the Micromedics. And that's considering Micromedics as a tertiary or a secondary resources because of that. So primary literature, as I mentioned, that it is from the question that you answer, it is an original article, either controlled trial, cohort study, case series, or case reports. These are the example of primary literature. Review article or editorials are not primary literature, so don't confuse with the review article. There are many review article published in the journal, and that's not considered as a primary literature. So after knowing different resources, primary, secondary, tertiary, we conclude with the primary. And we have one of the primary resources which is very common used in the practice, which is randomized controlled trials. So having a randomized controlled trial doesn't mean that the article is perfect. You need to evaluate every single information before answering a question, before extrapolating the data to the real life. So how are we gonna evaluate any article? We'll go through it. How we do critical appraisal? We'll go through it in the next few slides. So now, having these questions, so an open label randomized control trials means everyone participating in the trial is aware of assigned treatment. Patients are ignorant of assigned treatment. Investigators are ignorant of assigned treatment, or patients, investigators, and data evaluator are ignorant of assigned treatment. So now what's your answer will be? Where is it? Okay. So what's your answer now? So we have only 62% answering, so we need more answers. So this is your result now. 54% saying that everyone is aware about the study and the medication that's given. 13% saying patients are ignorant of the assigned treatment. 0% saying investigators are ignorant of assigned treatment. We have 33% saying patient, investigator, and data evaluator are ignorant of the assigned treatment. Actually, the right answer is the first answer. So it is an open label. So everyone knows about the assigned treatment. Patient, data evaluator, investigator, they know about the assigned treatment. Once we say that double-blinded, that's a different story. Double-blinded, that's the investigator and the patient, they don't know about the medication. Once we say triple blinding, or we have the full blinding, that the patient, investigator, and data evaluator, they don't know about the assigned treatment. When we have single blinding, that's only the patient doesn't know about the assigned treatment. So talking about randomized control trial, usually the population will randomly allocate to two groups. Either we give the intervention or a control. Either the control will be either a placebo or different medication or baseline medication that's given already. We have under specified follow-up period and specified outcomes. So before starting a randomized control trial, we have to specify the period of the study, and then we have to specify the outcome of the study. So randomized control trial, the healthcare professional must rely on the literature to keep the current on recent development on new treatment, as well as providing additional evidence on therapy. So accurate reporting of the clinical trial, yes, will help us as a clinical practitioner or a professional practitioner to adopt all this information to the clinical practice. So once we have a randomized control trial well done and well reported, that will reflect in the clinical practice. So we change sometimes current treatments to a new treatment because of randomized control trial. We exclude some patients from a treatment because of randomized control trial. We DC some medication. We change the first line to the second line, and switching the second line and makes it a first line in the guideline because of randomized control trial. So it's very important in our daily practice that we have different randomized control trial. We have different trials that published that change our practice on daily basis. So evaluating this, we need to evaluate all these things for the trial. We need to evaluate the journal first. Then we move to the title of the trial, author, abstract, introduction, methodology, result, discussion, and references. Every single detail of the trial need to be evaluated. And this is how we do a critical appraisal. So now the questions again. Critical appraisal of randomized controlled trial takes into consideration one of the following. So either randomization, blinding, benefit versus harm, or all of the above. So now is your answer. We have only 63% responding to the question. So either, so now reaching 66%. We need at least 70% answer. That's, I make sure that you are with me, not sleeping. So how about the rest? Okay, so now we'll share the results. So the majority of you saying that all of the above, which is 80%, and just 12% saying randomization, and just 2%, 8% saying blinding or benefit versus harm. So now we'll see. The right answer is, as you mentioned, all of the above. So while criticizing an article or randomized control trial, you need to know the randomization, blinding, benefit versus harms. You need to know all these things, and you need to evaluate all these things. So now again, the next question is, while evaluating a journal, what is the most important things to look at? So evaluating the journal. Where is the book? Now we'll move to the next question. So what's your answer? Either H index, journal title, impact factor, or journal design. Good, we have at least now we reach up to 80% response. So now I can continue my slides. So your answer is 58% saying impact factor. We have 19% saying H index. We have 8% saying journal title, and we have 15% saying journal design. So the right answer is impact factor. So while evaluating a journal, you need to know the impact factor. While you are comparing different journals, you need to know the impact factor. So the journal evaluation, either we we check different things. We ask ourselves different questions. So the first question that is our article published in a reputable peer-reviewed journal? Yani we need to know all these things. Is it reputable, well-known journal? For example, New England Journal of Medicine. Everyone know about it. Many articles published there. They don't publish any article, anything. They publish very good articles in their journal. That's why their impact factor is very high. So reputable peer reviewed يعني معناها سمعتها مرة كويسة. هذا reputable and peer reviewed journal. And what's the journal impact factor? So reputable peer reviewed journal, that doesn't mean that the article published without deficiency. So even in a very good journal, there is a deficiencies. So checking that and the two part of the journal itself. Once you log in the website, either there is an instruction for authors or a journal scope and purpose, and you know that it is a reputable or peer-reviewed journal, and the impact factor usually written in that part of the website. What's the meaning of impact factor? Impact factor is usually the number of citation of article, an average over a period of time, usually a 2 years or a 5 years impact factor. So for example, I publish an article in New England Journal of Medicine, and any other journal, for example, they publish another article and they took my article as a reference. So the New England Journal of Medicine will have a higher impact factor based on the number of citation of the article published in their journal. So you can find that once we have a high impact factor, that's mean the journal is a very good journal. So you can find that there is a Thomson Reuters website. You can search about any journal and it will give you the impact factor and the details. So this can help you to identify a journal. Usually journal impact factor above 1, it is good journal, usually, and a very specialized journal. But for a general journal, for example, for a New England Journal of Medicine, because it is cover many specialty, it have a high impact factor. So you can see this is the result from Thomson Reuters website. Impact factor, for example, this is many years ago, 55.8 for the New England Journal of Medicine, but now reach up to 70, I think. And we had a 5 years impact factor, and we have different results in the website. So that can help you to evaluate different journals, and you can know what's the rank of this journal in the same specialty. And it is all from this website, and it's very helpful for you. Now we're moving to the article itself, how to evaluate the article. So the title, so is the title informative? So we got all the information in the title, like for example, the keyword, study population, and the type of study. Is it unbiased? So we don't need a misleading titles. Specific, concise, no abbreviation. Concise, that means that usually it's 10 words. It is a concise title, and no abbreviation, except the abbreviation except in a very specialized journal. For example, saying writing an STEMI, abbreviation STEMI, which is ST segment elevation myocardial infarction, and in a cardiology journal, you don't need to write the full abbreviation. You can write the abbreviation itself. So no abbreviation, very general journal, but if it is specialized and well-known term, you can use that one. So now the next question. So we have this title, improved bronchodilation with levoalbuterol compared with racemic albuterol in patient with asthma. And this was published in a PubMed, and this was searched in PubMed, and this is published in a very reputable journal. So the question is this title is good or not? Yes or no? So the title again, improved bronchodilation with levoalbuterol compared with racemic albuterol in patient with asthma. So decide now. Any more answer? So no answer. So this is the results. So the majority of you, 56%, saying that, saying no, it is not a good title. And we have 44% saying yes, it is a good title. And the answer is the title lacking many things or not? Yes, it is published. And agree, once we see a published article, that we say that it is a good article. Oh, I see many questions here. Okay. So is it a good or not? Now you can see this title. So how about changing this title to the next title? So changing to bronchodilation from levoalbuterol compared with racemic albuterol in patients with asthma, randomized control trial. So the first title actually lack many things. It is biased because from the title you know the result. So improved bronchodilation with levoalbuterol compared with racemic albuterol. That means levoalbuterol is better than racemic albuterol. So from the title you know the result, which is not a good title. Again, the next title saying that bronchodilation from levoalbuterol compared with racemic albuterol, that doesn't give you any answer, doesn't give you any conclusion from the title, and the type of study is mentioned there, and it's very concise and it's very good title. So this one is a biased title, and this is very good example showing you that many articles published and in the journal that have deficiencies. So you need to be sure that not every article published that's a good article. So now again, the authors. Is the author have any conflict of interest? Is the author qualified to do this research? And the H index of the author. So I usually like these pictures. Is the author getting funds from any company, for example? Is the author is not specialized or not qualified to do a research? That needs to be evaluated. And this is how we know that the author productivity. So let's say that I'm saying that I'm a researcher. I do many research. So how do you know? You just Google my name? No. It is through the Scopus. This is one of the websites that can evaluate the authors. So H index is like an impact factor for a journal. H index just to evaluate the productivity over years for the researcher or the author. And this is the example. I just take an example, which is Ball, for example, have different article published, 56 paper, and the H index was 10 of this author, and the co-author, he was cited as a co-author for 124 times. I have a question saying that, could you please explain what does index mean, because it confused the term. index mean يعني بالعربي نقولها مرجع، يعني مرجع او رقم مرجعي لاي مجله. مثلا المجله لما نقول امباكت فاكتور او نقول اتش اندكس، اتش اندكس معناها انه هذا الرقم المرجعي للشخص هذا، يعني كم مره عمل ريسيرش خلال سنوات. طيب I hope that I answered the questions If you have any question, just write it in the question Q&A bar, so I can answer it at the end of the presentation. So this is the H index to show you the productivity of the author. يعني الباحث تشوف نشاطه خلال سنوات، هذا ال H index. يعني كل ما زاد ال H index كل ما معناها انه الاوثر هذا نشط واكتف to do many research every year. So now we'll move to the next part, which is the abstract. So abstract include all the information, should include all the information, the objective, method, result, and conclusion. Primary use of the abstract is to have an immediate overview. So from the abstract, you know, is the article, is the answer of your question in this article or not? Are you interested in to read all the things in the article? From the abstract, you can save your time. Just read the abstract. If you are interested more, you can go over all the detail of the article. And we have two different kinds of abstracts, either structured abstract or non-structured abstract. And now this is the old-fashioned, the journal, they write the full sentence, it's not structured. And nowadays, most of the journal require a structured abstract, which is separated, the background alone, methodology is separated, the result part is alone, and we have the conclusion at the end. So the abstract should be clear, concise, no abbreviation, have all the information about the background, purpose, method, result, and conclusion. All numerals for numbers, use numeral for numbers, except for in the beginning of the sentence. So we need in the beginning of the sentence we need to write the full term of the number. For example, 24, you need to write it in a full sentence. If it is in the middle, you can write the number as it is. So this is the criteria of evaluating an abstract. Now the introduction part, we have two things in the introduction part, which is either the study rationale or the study purpose. And for example, this is one of the examples published in New England Journal of Medicine, oral rivaroxaban for the treatment of symptomatic pulmonary embolism. And the study rationale, there is no clinical trial evaluate the role of rivaroxaban in the treatment of symptomatic pulmonary embolism. And usually it is a missing gap. Yani, once you want to do a research, either you don't have any information about these things and you want to investigate to have the answer, and which is the gap of information. And the study purpose is usually start with to evaluate or evaluating the concept of using rivaroxaban alone for anticoagulant therapy for pulmonary embolism, replacing both heparin and vitamin K antagonists. So the study purpose usually, or we call it the objective of the trial. Why we are doing this trial is to evaluate rivaroxaban compared to warfarin, for example, rivaroxaban compared to heparin. But the study rationale is the gap of knowledge. So we have missing information. We need to have the answer, and this is why that's why we do this study. And we have one term, very important term in the trial, the alternative or research hypothesis, and we have the null hypothesis. The research hypothesis, that means that we have a difference between, we hypothesize, يعني نفترض إنه we have a difference between the medication or the investigated medication compared to the placebo, compared to the control. So intervention compared to the control, we have a difference. يعني عندنا فرق بين الكنترول والintervention. The null hypothesis, there is no difference. We hypothesize that there is no difference between the investigation medication and the control. The methodology part, which is very important things, that when you evaluate the randomized control trial, you need to know the study design, either the medication randomized control trial, or what's the kind of study, blinding, is it single blinding, double blinding, triple blinding, is it single center, multi-center? All this information is very important. Duration of therapy, how long they are giving this medication. So let's say, for example, giving rivaroxaban or giving warfarin for patient with BE for 1 month and saying that it is better than heparin from 1 month. And this is not within the guideline. This is not within all the evidence. So you need to evaluate at least for 3 months. And this is the guideline saying. So doing a study of less duration, that biased study usually, and we need to be careful with these things. So duration of therapy is very important. IRB, the Institutional Review Board, is the protocol of the study is approved by the Institutional Review Board. We need to know that. Informed consent is the patient is knowing that he is getting a medication for study or not, and he need to sign the consent for the medication. Sample size, is it enough to show significance or not? Subject recruitment, how they recruit the patients. Did they recruit them through websites, advertising, through the hospital? How they include the patients? Inclusion and exclusion criteria. We need to know all these things. Is the inclusion and exclusion criteria is right or not? Is for example, the medication is contraindicated and it is included and the inclusion criteria, and this is wrong and need to be evaluated. So allocation of the study subject, is it 1-to-1, 1-to-2, 1-to-3? For example, I have the intervention group, which is 300 patients, and the placebo group, which is 100. That means that 3-to-1. So we have 3 patients in the intervention group, and I have 1 compared to 1 placebo. And that's very important. The compliance of the patient. Is the patient taking all the medication? How they monitor the compliance, how they make sure in the study the patient is taking all the doses to show the significant result. Now, from the methodology, we have, I mentioned all the time, the intervention, and control group. So the intervention is the medication or the procedure itself. The control group is either no therapy, which is placebo, we give a placebo tablet, or another therapy, which is active control, which is medication that's already known and already we have an evidence for it, or we are comparing to the historical data. So study is already done previously, and we are comparing to that study. And this is just an example. We have ergotropan anticoagulant therapy in patients with heparin-induced thrombocytopenia. So that's comparing ergotropan to to placebo for patients with heparin-induced thrombocytopenia. Now we have many things that's called primary endpoints, secondary endpoints, the methodology part, or composite endpoints. So the primary endpoint usually what the investigator measure to achieve the study objective. So, for example, the primary endpoint of giving carfidolol compared to placebo is to reduce blood pressure to the target. So my primary endpoint is to reduce blood pressure to the target. The secondary endpoint is, for example, safety profile. Composite endpoint, that's mean different primary endpoints. So we have like multiple primary endpoints measured in one statistical analysis. And again, this is another example. Atorvastatin versus simvastatin in managing dyslipidemia. So the primary endpoint was change in LDL. So giving atorvastatin will reduce the LDL, the low density lipoprotein. The secondary endpoint would change in the liver enzyme, which is a safety profile of atorva and simvastatin. So is there any adverse drug reaction? Is there any side effect compared atorva to simva? And the primary endpoint is changing efficacy. So efficacy and secondary endpoint is safety. And we have different examples for this is an example for composite endpoint, which is a comparison between low molecular weight heparin with unfractionated heparin for unstable coronary artery disease. And this is published in New England Journal of Medicine in 1997. So the primary endpoint is a composite triple endpoint. So we have different endpoints to be measured, either death or myocardial infarction or reinfarction or recurrent angina at 14 days of follow-up. So all these things as a primary composite endpoint at day 14. So the result is showing that the composite endpoint at day 14, the composite triple, death, myocardial infarction, or recurrent angina, is the B value is 0.02. And I'm sure that all of you knowing that the B value less than 0.05 is a significant. So the composite endpoint is very significant, which is 0.02 for all these things, death, myocardial infarction, recurrent angina. But that is a misleading statistical analysis. So when you go in detail, death was not significant, which is more than 0.05, which is 0.92. Myocardial infarction, which is, again, not significant, which is 0.06, which is more than 0.05. And recurrent angina, which is 0.03, it is less than 0.05, which is significant. So recurrent angina, it is the only one significant. So death, myocardial infarction was not significant. And that's a misleading information. So death is very important. Myocardial infarction is very important. The least important things, is recurrent angina. So, and it is the only thing significant. And that can lead you saying that low molecular weight heparin is better than unfractionated heparin and stable angina from the study. And this is published in a very reputable journal. And if you don't evaluate all these things, you will change your practice and a wrong recommendation or a wrong or a misleading article. Statistical analysis, I will not go in deep in statistical analysis because it will take a special session or a 1 week session to talk about statistical analysis, what's the difference in a statistical analysis. So just an overview, a general overview, we have two different types of data, either qualitative or categorical data, nominal or ordinal. For example, the nominal, the hair color, the sex. The ordinal data, which is the grade, we have grade 1, 2, or 3, for example, of malignancy, degree of pain. The quantitative, which is a continuous, which is like, for example, LDH, cholesterol, which is accepting a fraction, يعني تقبل الفاصلة, or discontinuous or discrete, which is doesn't accept any fraction in it. This is very important. I like this slide. It's very important for all the people that are taking SPLE or Saudi Council exam, board exam. This is very important things to know that about all these 10, the relative risk ratio, or absolute risk ratio, or number needed to treat, and how to calculate it. So risk ratio, relative risk ratio, absolute risk ratio, or number needed to treat. So we have this table, we have the group, yes or no. We build this table. We have the intervention, either A or B, and we have the control C and D. So, and this is the result. So intervention is the adverse effect happen? Yes. So what's the number? Is the adverse effect did not happen? How much? So we put the number. And the control part, for example, the placebo, do we have adverse drug reaction? How many? The patients does not experience any drug adverse drug reaction. We put the number here. So having A over A and B, A over A and B divided C over C and D as a sum give you a relative risk. Relative risk ratio, it is 1 minus the relative risk, 1 minus the RR. Absolute risk ratio or risk reduction, which is C over C and D, minus A over A plus B. So just know all these things, which is the percentage of subject treated with interventions paired to the adverse drug event. So we'll go in an example, a real life example, so you can know all these things. Number needed to treat, which is 1 over absolute relative risk. So, which is number needed to treat, that means that number of subjects need to be treated to have one adverse effect. Yani, we treat, for example, 30 patients and we'll have one adverse effect. We'll have 30 patients treated, then we'll have this result. So let's take this example to understand. We have this trial, randomized trial of cholesterol lowering agents in 4,444 patients with coronary heart disease, the Scandinavian simvastatin survivor study. They call it 4S trial, published in the Lancet. So the total number of patients, we have 4,444. The simvastatin group, 2,221. And the placebo group, which is 2,223. And the number of deaths in each arm, 182 in the simvastatin group and 256 in the placebo group. So let's do the calculation together. So 182 over the total, we say A over A and B, the total. So we have 182 deaths over the total number, which is 2,221, over 256, which is the number of deaths, over the total, 2,223, which give you 0.7. So the relative risk is less than 1, which indicates that simvastatin lower the risk of death by almost 1/3 of the baseline compared to placebo. So 70% is the death reduced compared to the placebo. So the relative risk ratio, so we have 30% lower by treating subjects of simvastatin instead of placebo. So 1 minus 0.7 multiplied by 100 to give you the percentage, which is 30%. So we have a 30% reduction in the treatment group and number of deaths compared to placebo. So we have 256, 30% lower, which is the intervention simvastatin group, and number of deaths. So we have 30% difference. The absolute relative risk or risk reduction, simvastatin, which is 256 over 2,232, which is 11%, versus the placebo, which is 8.2%. And the difference between both of them is 3.3%. So this is the absolute risk reduction. The number you need to treat, we give 1 over 0.033, which is the 3.3%. You divide it by 100, it will give you 30. So you need to treat 30 per patient for a 5.4 year to prevent 1 death. So يعني نعالج 30 مريض لمدة 5 سنوات عشان نمنع 1 death. فهذا النمبر you need to treat. This is the number you need to treat. You need to treat 30 patients for a good period of time, the study period of time, which is 5.4 years, to prevent 1 event. Now we'll go to the statistical analysis. I know I have 15 minutes, so I need to rush. Confidence interval. Everyone of us know about confidence interval. It's very, very known that we use a standard deviation in the article. We have the 99% confidence interval, we have 95% confidence interval, and we have 68% confidence interval. And what's that mean? That means we have 1 standard deviation, which is the 68%, 2 standard deviation, which is 95%, and 99%, which is the 3 standard deviation. What's the mean of 99% confidence interval? That means I'm sure 99%, if I repeat the study with a similar methodology, I will have 99% of the result we have the same result. 99% of our result will be similar to the previous trial. يعني إذا عدت الدراسة بيطلع لي 99% من الريزلت متشابه مع الدراسة الأساسية. We have 2 different types of error that's commonly used, type 1 error and type 2 error. I will not go through them because of the time. In a quick way, that type 1 error usually incorrect rejection of the true null hypothesis. And for example, of type 1 error, that's a test that show patients have a disease when in fact doesn't have the disease. We use a test and showing, for example, COVID test. We test a patient and showing the result is positive and the patient have COVID. And in actual, the patient does not have COVID. And this is type 1 error and called alpha error. Type 2 error, which is the failure to reject false null hypothesis. And the type 2 error would be, for example, a blood testing for failing to detect the disease itself. So again, the same example, COVID-19 test, I do a swab and the patient showing, the result showing the patient's negative, while actually the patient have COVID. So this is the type 2 error, which is beta error. Now, that's the question of our, I keep sharing my questions. So the last question is patient should be analyzed. Patient should be analyzed in the group to which they are randomized, intention to treat analysis, regardless whether they receive the treatment or not. So the patient will be analyzed, the data will be analyzed, whether the patient received the treatment or not. So what's your answer now? So we have 67% response. So your answer is saying true, is 81% saying true and 19% saying false. So let's stop sharing this. So the right answer is intention to treat. Usually we include all the patients that's included in the study from day one. Once if they receive one tablet or one dose of the medication or one dose of the intervention, they will be included in the analysis. Yes, this is the intention to treat analysis. Per protocol, that's only the patient's per protocol analysis, that's all the patients will be included in the analysis if they complete the study. So they don't include the patient that's dropped from the study. So this is a per protocol. Intention to treat, they include all patients, whether they complete the study or not. So now the result part. So number of patients that screened, enrolled, administered the medication, completing the medication, withdrawing from the study need to be evaluated. The demographic between the two groups, is the demographic similar? So we have the similar age, average, similar serum creatinine, similar characteristics or not, and need to be evaluated. And the result is the result statistically significant or clinically significant difference or not. So we'll have a different example for the term of statistically significant or clinically different. For example, a patient's getting an hypertensive therapy, lowering the mean blood pressure, systolic blood pressure by 14 millimercury versus 3 millimercury for the placebo. So the medication lowering the blood pressure by 14 millimercury, while the placebo just lowering by 3 millimercury. So for the patients, his mean diastolic blood pressure is 98 millimercury. So in this case, we consider it as clinically different due to the 11 millimercury average difference, and subjects are achieving goal systolic blood pressure from the baseline of 140 millimercury. What's that mean? if I say that the patient baseline systolic blood pressure is 140, and the guideline saying that your target is 120, reducing by 14 millimercury will not reach the target. So that's not clinically different. And 3 will not reach the target, which is not clinically different. So both of them, the medication and the placebo, will not reach the target. So the clinically difference, they are not clinically different. For example, if the 14 millimercury reach the target and the baseline, for example, is 130, we'll say, yes, this is a clinically different. Again, this is another example, atorvastatin lowering the LDL by 1.7% greater than simvastatin, and that considered not clinically different for a patient with LDL 181. So if you reduce 181 by 1.7% or 73% for the placebo, for the medication, and 5% for the placebo, or for the simvastatin, simvastatin versus atorvastatin. So atorvastatin will reduce by 37%, and simvastatin will reduce by 35%. And both of them will reach the target, which is less than 120%. So that means they are statistically significant, but not clinically different. We have 8 minutes to finish. I hope this is clear. So we have clinically different and statistically different. So could be there is a statistical difference, but no clinical difference. So statistical significance is different than clinical difference. So clinical difference, that means in the clinical practice, do we reach the target or not? Do we achieve our goal clinically or not? Statistically significant, that means only numbers. So I have, for example, simvastatin is better than atorvastatin by numbers, but not reaching the target. That's not clinically different. The conclusion part and the discussion part should be evaluated. So the conclusion is biased. So is the conclusion similar to the result part or not? Is the trial limitation described? For example, we have they should mention that number of patients that's dropped from the study, number of patients that did not complete the study, number of patients that have adverse drug reaction. They have, for example, missing doses. For example, in the methodology part, they have different limitation because of statistical analysis. They need to mention all these things in the trial. If not, that's mean a bias. Is the trial is extrapolated to all population or not? For example, doing a single trial in one hospital doesn't mean that all the hospitals have the same population. Again, let's say that I'm doing my study in the Dammam medical complex, and I say that all Saudi population will have a better outcome when they have this medication based on one trial or based on one study in the Dammam medical complex. That's totally wrong. We cannot extrapolate the data to all population. For example, I did one trial in the US, and again, I need to apply it in the kingdom and the Saudi people. So that doesn't extrapolate. The data cannot be extrapolated to our population. So we need to have a multi-center trial, for example, to be extrapolated, to have the data extrapolated. So again, is the reference is current? So is the reference in the article is recent, not old references? Is a comprehensive list of published articles related to the trial objective presented? So do we have a very good number of references, and they are related to the study? So we don't present any references that not related to the study. We can use simplified forms to do a critical appraisal. For example, this is another example. The CONSORT, if you search in the websites, you can have the CONSORT 2010 will give you all the things all the questions that to evaluate any article about the title, the background, the introduction, the methodology, the result, the blinding, everything, even the discussion part, the references, everything is there. The last part of my presentation, I take a long time. So now the evaluation of the internet resources. So I promise that within 3 minutes that we will finish. The internet resources, not every website is trustable website. So you don't trust any website. You do not go just through Google and just search anything. So the websites, you need to consider the source, who is responsible about the content of the website. So you need to go to the website and you just click about us. So you need to read who is responsible about the website. Quality. Are the author or editor is expert or not, or just people just like the Twitter, for example, they write their thought and people will believe that their thought. So we don't believe or rely on people's thoughts. We need an evidence-based practice or evidence-based article. So is the information that from the expert people, how is the information selected or approved in the website? Look for the evidence. Does the website identify the author? So do we have authors or anonymous authors? Does it reference, or do we have an information about the reference of the content of the website? The currency, is the information is current, updated or not? And be aware of bias. So who's sponsoring the website? Is it sponsored by company? Is it sponsored by anyone? Are they trying to sell something or not? We need to know all these things. And this is a summary. Who ran the website? What's the purpose of the website? Is the website a trustable website? For example, is it .edu, for example, .gov? That means that's the governmental agency or education, academic institution that's running the website. So you need to ask yourself all these questions to evaluate the website. And that's it. Thank you for listening. And if you have any questions, feel free to ask me. We'll have 5 minutes for questions. I hope that every single point that you understand it. I try to simplify it. I know many things that need to be covered in this presentation, but in 1 hour we cannot cover many things. I have a question: how I can practice on trials evaluation? Yes, we do. Usually, we check the trial, we evaluate the trial. If there is any bias in the trial, is there any answer is there any point of the trial that's misleading me? So once I have everything clear in the trial, then I go and practice all these things from the trial. Let's say, for example, I have a patient have an LDL of 300. And they have atorvastatin and simvastatin and bravastatin, and I have a trial saying that atorvastatin will lower LDL by 60%, and simvastatin is lowering LDL by 20%. So which one I choose for those patients? The trial saying is atorvastatin reducing is higher and statistical significant, and there is no bias in the trial once I evaluate, and the population in the trial is multi-center. I can apply it in our population. Yes, now we can apply all this information in our patients. So this is how we practice or how we use the trial in real life practice. Any other questions? So we have 2 minutes for questions. Any other questions? Anyone like to open the mic and ask? Feel free to. If you want to open the mic, just raise your hand through the Zoom. I can open it for you. Any other questions? No questions? So thank you for listening, and I hope that you enjoy the presentation. Let's see if there is any other questions. So we have there is a question saying that will you please send the recording and the PowerPoint? So this is based on the organizing committee, if they would like to share the video or the recording, that will be okay with me. Fatma, is the slide is biased? Yes, I'm biased to my slides.